Dr. Humara, thank you for your excellent presentation. So maybe we will just hold you as to answer any questions. I don't think we need to have you present again on vertical transmission, if that's okay. So let's start with Mr. Muhammad Usman. Great. If you could perhaps share your thoughts on, from a civil society point of view, correct, on access to treatment and PrEP from a client and provider perspective.
Thank you so much. I would like to start with some good practices, basically, which are happening in Islamabad specifically when we talk about the treatment centers. So I mean very much sensitized toward the gender sensitization and sexualities. So I mean this is a good practice that we have in here. Secondly, when we talk about the treatment access and PrEP with the perspective of clients, so I mean there are some hindrances, there are some problems I mean with the clients are getting as well. So there are like the community wakes up late, but the treatment center timing is less and they closes at 2. So this is the also a problem. Except to that, I mean the medicine which we are getting is only for 1 month, and which we are doing the testings for the follow-up after 3 months. So I mean there is also a gap. So this is not the problem. I mean we are getting the PrEP only from the treatment centers, but this can be a problem in somehow, just not because of confidentiality. It can be a problem due to some confidentiality related to the partners, because they're all getting on the same treatment center where the HIV people are getting treated. So this is also a hindrance of not going to the treatment centers to get the PrEP. So this is basically a problem. Yes. Thank you.
Thank you. Mr. Ghulam Raza, perhaps you can share with us on some of the differentiated service delivery practices that your organization is implementing.
Yeah, I will be co-moderating along with Ghulam Raza, as he's Urdu speaking, so I'll be co-moderating.
Okay, great.
ख़वातीन व हज़रात अस्सलाम वालेकुम। मेरा नाम गुलाम रज़ा है, मैं ज़िला सरगोदा से ताल्लुक़ रखता हूँ। आजकल बतौर काउंसलर AAU फैसलाबाद में काम कर रहा हूँ। मैं अपने इस फॉर्म के ज़रिए मुझे अपने तजर्बात के इज़हार का मौका मिला कि टीके के ज़रिए नशा करने वाले भाई और HIV में मुब्तला भाइयों के ख़ानदान और उनके मसाइल में बात कर सकूं।
Assalamu alaikum. My name is Ghulam Raza. I am from Sargodha district and currently working as a counselor at AAU Faisalabad. Through this forum, I have been given the opportunity to share my experiences and to talk about the issues faced by people affected by HIV and their families due to drug addiction.
जी, टीके के ज़रिए नशा करने से सिर्फ जिस्मानी बल्कि मुशाती मसाइल का भी सामना करना पड़ता है। यहाँ मुआशरा नशे करने वाले को कबूल नहीं करता, वही उनके ख़ानदान के साथ रवैया इम्तियाजी रवैया रखा जाता है, जिसकी वजह से एक इंसान की वजह से सारा ख़ानदान, एक शख्स की वजह से सारा ख़ानदान तबाह हो जाता है। इन हालात में कुछ ख़ानदान ऐसे होते हैं जो हम जैसे लोगों से तल्लक कता करना ही बेहतर समझते हैं। ऐसे हालात का सामना मैं और मेरे साथ बैठे स्पॉट पे बहुत से भाइयों ने किया है।
Drug addiction through injection not only leads to physical problems but also social issues. Society doesn't accept drug addicts and their families and are also treated with discrimination. As a result, an entire family is destroyed because of one person's action. In such situations, some family thinks it's better to cut ties with their loved ones. And many brothers sitting with me on the spot have faced similar circumstances.
नई जिंदगी की स्पॉट से उठा के हमें यहाँ तक पहुँचाना कोई आसान अमल नहीं है, क्योंकि जिस वक्त स्पॉट पे बैठे हम नशा कर रहे होते हैं तो नशे के दौरानिए में हमारी जो नशे की साइकिल होती है वो नशे में ही घूम रही होती है कि नशा कैसे लेना है, कहाँ से लेना है, पैसे कहाँ से करने हैं, हमारी जो है साइकिल वहीं पे घूम रही होती है। तो इस चीज़ का एहसास दिलाना कि हम कहाँ खड़े हैं, ये नई जिंदगी के जो भाई हैं घंटों घंटों जो हैं उस स्पॉट पे खड़े होकर सिरिंज मुहैया करते हैं और हमारे नशे की साइकिल को तोड़ते हैं। इसको तोड़ना बहुत बड़ा अमल है कि HIV का टेस्ट करना, HIV के राजदारी का ख्याल रखते हुए ये गाड़ी में टेस्ट किया जाता है, फिर टेस्ट HIV पॉजिटिव होने के बाद ART सेंटर लाया जाता है। ART सेंटर ARVs इशू करवाई जाती है। ARVs को मामूल और ART सेंटर से AAU का सफ़र जो है वो नई जिंदगी जो है बड़े अच्छे तरीके से जो है सरंजाम देती है। ये मुद्दत, ये हदूद जो है, ये सर्विस की हदूद सिर्फ नई जिंदगी AAU तक अगर महदूद नहीं, बल्कि AAU में हमारे जो है जब नशे से निकालने के लिए हमारी मदद की जाती है और नशे के निकालने के बाद ARVs की अफादियत के बारे में बताया जाता है। डॉक्टर हजरात और साइकोलॉजिस्ट मैडम HIV के साथ मुस्बत तर जिंदगी गुजारने के तरीक़ेकार बताते हैं।
For our Nayi Zindagi, it's not an easy task for Nayi Zindagi staff to bring us from the spot to this point. Our lives sitting on the spot were just revolving around the cycle of drug addiction. Where to get drugs, when to get them, how to get them, and where to sit and use them, and how to get the money for it. Breaking this cycle and making us realize where we stand is not an easy feat. For hours, Nayi Zindagi staff stand on the spot and register us. They provide new syringes with confidentiality maintained. Our HIV test is conducted in the van, and if positive, we are taken to get ART treatment. After testing for Hep B, the baselines are done. We are facilitated to obtain ARVs and then transported to the AAU. That is basically ART adherence unit, our treatment centers. For further treatment, Nayi Zindagi Trust staff is doing a great job of taking care of us. These services are not limited to just reaching AAU, ART adherence unit, a residential rehabilitation facility for HIV positive persons who inject drugs, but also include taking care of us, rescuing us from the troubles of addiction and educating us about the benefits and use of ARV. At ART adherence unit, doctors and psychologists counsel us on how to live a positive life with HIV, and after completing the treatment from center, and Nayi Zindagi teams remains in contact with us and help us solve our problems.
जैसा कि मैंने पहले जिक्र किया है कि एक नशा करने वाले की वजह से सिर्फ एक इंसान नहीं बल्कि उससे जुड़ा हुआ पूरा खानदान को मसाइल का सामना करना पड़ता है। फिर वो माली हालात हों या सेहत के मसाइल, नई जिंदगी इन दोनों पहलुओं को बहुत खूबसूरती से निभा रही है, समझते हुए निभा रही है और बहुत से भाइयों के खानदान को सपोर्ट कर रही है।
As I mentioned earlier, when someone becomes a drug addict, it's not just the individual who suffers, but the entire family connected to them also faces problems. Whether it's financial difficulties or health issues, Nayi Zindagi Trust understands both aspects very well and is supporting many families like mine who have been affected by drug addiction.
शादीशुदा अफराद के बीवी बच्चों का टेस्ट करना, उनके घर जाकर आगाही फराहम करना, HIV में मुबतला होने की सूरत में ART सेंटर लेके जाना, ARV मुहैया करना, वालदान से बच्चों को HIV मुंतकिल होने से बचाने की सर्विस और हर 3 महीने के बाद राशन की सपोर्ट करना, ये तमाम सर्विस हैं जो उनकी बदौलत हम और हमारे खानदान वाले एक अच्छी और सेहतमंद जिंदगी गुजार पाते हैं।
Testing the wives and children of married individuals, providing them with HIV testing at their doorstep, and if infected, providing ART treatment, ARVs, medicines, and services to prevent HIV transmissions from parents to children. Additionally, providing rations after every 3 months, that is our LSP program. These are all the services that enable us and our family members to live a healthy and happy life.
इस फोरम की मदद से मैं कुछ ऐसे मसाइल का भी जिक्र करना चाहता हूं जिनको हल करके हम इन तमाम सहूलियात को बेहतर करके मुतासर कम्युनिटी के लिए सेहत के वसाइल को बढ़ाया जा सकता है।
With the help of this forum, I also want to mention some issues that need to be addressed in order to improve these facilities and increase health resources for the affected community.
ART सेंटर के नुमाइंदगान भी यहाँ पे मौजूद हैं। मेरी दरख्वास्त है कि शनाख्ती कार्ड के बगैर दवाई के असूल को यकीनी बनाया जाए। बहुत से लोग सिर्फ शनाख्ती कार्ड ना होने की वजह से HIV के इलाज से महरूम रह जाते हैं। वसाइल की कमी की वजह से हमारे लिए हर माह ART सेंटर जाना मुश्किल है। हमें 3 महीने की ARV मेडिसिन मुहैया की जाए और इसके साथ साथ हमें इसकी भी इजाज़त होनी चाहिए कि हमारे लिए घर में से कोई भी ऐसा फर्द जिसका हम नाम मुंतखब करें और हमारे लिए ART सेंटर से दवाई ले सके।
Representatives of ART centers are also present here, and my request is to ensure that medication is available without an identity card. Many people are deprived of HIV treatment simply because they don't have any identity card. Due to lack of resources, it's difficult for us to visit the ART center every month. We should be provided with a 3-month supply of medicine, and additionally, we should be allowed to authorize a family member to collect our medication from the ART center on our behalf. This would make it easier for us to access treatment without having to visit the center every month.
यहाँ नई जिंदगी के सीनियर लोग मौजूद हैं। दरखास्त करना चाहूँगा कि नई जिंदगी के रहायशी ट्रीट सेंटर यानी कि AAU में सिर्फ एक दफ़ा इलाज का मौका मिलता है। इस हवाले से मेरी दरखास्त है कि हमें किसी किस्म की मुश्किलात का सामना करना पड़ता है तो हमें दोबारा इलाज का मौका मिलना चाहिए कि नई जिंदगी।
There are also senior members of Nai Zindagi Trust present here, and I would like to request that we are given only one chance for treatment at ART adherence unit. And this regard, my request is that if we face any problems, we should be given another opportunity of treatment.
नई जिंदगी का एक प्रोजेक्ट शुरू हुआ है, सिंध में एक प्रोजेक्ट शुरू हुआ है जिसमें नई जिंदगी के डॉक्टर नई जिंदगी का बाकी स्टाफ स्पॉट पे ARV अद्वियात फराम कर रहा है। मेरी दरखास्त है कि ऐसी सहूलियात पंजाब में भी शुरू करवाई जाएं क्योंकि इनको ज़्यादा ज़रूरत पंजाब में है। इसकी ज़रूरत ज़्यादा पंजाब में है और हज़ारों की तादाद में लोग जो HIV में मुब्तला हैं, इनको इस प्रोग्राम की अशर ज़रूरत है। मैं तमाम मेंबरान का शुक्रगुजार हूं जिन्होंने इस कॉन्फ्रेंस का इंतकाद किया और मुझे अपने ख्यालात का इजहार करने का मौका दिया। और आखिरी अल्फाजों के साथ एक शेर है कि जब तक बिके न थे कोई पूछता न था, नई जिंदगी ने खरीद कर अनमोल बना दिया।
Wow. The last point he's saying is that I have read that a project called C19RM has been launched in Sindh by Nai Zindagi Trust, where doctors and Nai Zindagi staff are providing ARV medicine on the spot. My request is that such facilities should be started in Punjab, where thousands of people affected by HIV and struggling with drug addiction urgently requires this program. I am grateful to all members who organized this conference and gave me the opportunity to express my thoughts. Thank you.
Thank you very much, Mr. Ghulam, for your thoughts on how Nai Zindagi is providing very important services for both people who use drugs as well as the HIV treatment that they need to receive. Mr. Siddiq Wali from Humras, it was already mentioned that an important component of the services provided in Zindagi, one of which is partner notification. I believe you're going to speak to us on how Humras does that for female partners of key populations.
Thank you, Deepa. I'll be brief. I don't want to be that person to get between you and the lunch. Basically, when we talk about treatment for all, so that is a very effective way, a strategy to for prevention of HIV. One of the strategies. So when we talk about partner notification with MSMs, like the Hamraz is working with MSM population, there are many MSMs who are married, who have their spouses, and many of them have female partners as well. So when a person gets like HIV positive, there is a protocol, or you can say a strategy, where we always ask them to bring their partners, spouses. They can be trans women, so like their partners basically. So with that, most of the time, because now we are working for like almost like 12 years, we know how to go with it, how to handle that situation, because The biggest challenge which we face with this is with the consent of the client, the MSM, the PLHIV, because as being MSM and having this behavior of like having sex with male, having a female partner or a wife, it is very difficult for them to tell their spouses about HIV and bring them to the treatment center or the CBOs to get them tested and to know their status, and if they are like negative, so put them on PrEP or like the options we have available for prevention. So the first challenge which we face is the consent. Secondly, if I say that they have this fear of confidentiality. Again, when like there have been incidents where PLHIV coming out to their spouses and things go south, and they get divorced, separated. There have been like incidences where there is like the social barrier or the social challenge is more than the clinic one. So so I'll be like very brief with it. Like if we want to like tackle this challenge and making sure that every partner of a PLHIV go to treatment or at least get tested, go on PrEP, we need to like win their trust first of all, making sure that confidentiality is there, and I think encourage them to bring their spouses to the counselors, to the psychologists who are present, doing couple counseling, because most of the time what we have seen that when people try themselves to let their spouses know, mostly the things go south in that situation. So that is better to take some professional help doing that, and yeah, that's my 2 cents. Thank you.
Yeah, thank you very much. Certainly from my own personal practice, this can be one of the most tricky and difficult things to navigate to the partner notification side of things. Before we open the floor to questions to all of you, perhaps we can hear from Mr. Omar Haider from the Association of People Living with HIV on what measures you take to improve retention on treatment.
You know, before we can talk about measures to improve retention on treatment, we have to identify the reasons why people fall off treatment. There are many reasons, such as there is stigma and discrimination faced from within the communities, at the healthcare facilities. We have people who, after a few years of taking ARVs, they start feeling well, and there is a lack of counseling, there is a lack of this information that you have to take this as a lifelong treatment, and then there are issues like distances and timings to ART centers and misguidance by quacks, especially in Pakistan, and people go for like these herbal medications and other things like what we call Hakim Ilaj. So, you know, in countries like Pakistan, the health systems are more, they are looking towards acute diseases. You know, but a chronic disease like HIV, there are hardly any information about it, or hardly any interventions for that at the bigger scale. A lot of us are working in the HIV sector to increase retention, but you know, a lot of the time there is duplication of services. People are working in silos without any communication with each other. So you know, a lot of efforts are being wasted. So in my opinion, and in my organization's opinion, there is a three-pronged strategy that we can do to bring more people onto the treatment and retain them on treatment. One could be a healthcare facility, health system based, such as, you know, you can timely identify people. We have some systems in place for identifying people who are lost to follow up, but there should be systems who identify people who are struggling with with adherence before they are lost to follow-up. Because if you can catch them at that point in time, they are still coming to the ART center, they are maybe missing a few doses, or they are missing 1 or 2 appointments. So before, you know, they go to, they disappear for like after 6 months or a year or whatever, we should have systems in place which can identify people who are struggling, and for this we will need better counseling, better gender sensitive, key population sensitive counseling, which can be used to identify people who may be struggling with adherence. Then, you know, we need to have patient centered approach, you know, which is earlier initiation of ARVs, because studies have shown that even a small gap in ART initiation can lead to troubles in the future. And then, you know, differentiated service delivery. Differentiated service delivery, because this will also open up and provide time and space for the healthcare providers to give more attention to the people who are struggling with adherence. You know, people who are stable, who have suppressed viral loads, they can receive their ARVs through communities, through other channels which can be explored. We ourselves as APL HIV, we have published a document on DSD service delivery. Those can be looked into. And lastly, you know, behavior interventions, which could be through community outreach, through peer counseling, and sustained adherence counseling. Because, and in all of this, I personally believe that, you know, we should have the communities at the center of these. You know, there are programs who are working, who are doing a very good stuff. But, you know, the community element, it is there, but very little involvement of the communities there. The communities, the key populations, the general population, they understand their own patients much better than, you know, the programs and implementers. So, you know, with the help of the communities, we should all work together hand in hand to keep people adherent on HIV treatment.
Excellent. I think those are all excellent suggestions, which brings us to opening up the floor to questions. Before we do that, may I invite Mr. Salman Qureshi back on stage to join the panelists, as members of the audience may have questions for you as well. Thank you. I need to stand to see who's putting their hands up. Okay, I believe the gentleman on my right here
thank you very
has
much.
a question.
So, biggest barrier to access to the treatment in Pakistan is the limited number of ART centers in the country. So why not to integrate ART services into the primary healthcare services?
That's an excellent suggestion. Is there anyone on stage who would like to take that question? The suggestion is to integrate ART centers into your primary healthcare settings. Go ahead, yeah.
Even better.
Whilst the mic, did you want to say something?
I think, sir, it is proven around the world that, you know, differentiated service delivery has given excellent results, and, you know, the program implementers are here, a lot of decision makers are here. So we should, as communities, advocate for this, because, you know, especially for people who are stable, who are adherent, because like I said before, it will free up valuable resources at the ART centers to provide, you know, a patient-centric approach for people who may be struggling with ART adherence. So I agree with sir, and looking forward to Dr. Faisal's input on this as well.
Please go ahead.
I was going to say exact same thing. So I think DSD is the solution for that, for moving into primary healthcare setting. In fact, we've also done initial work in terms of trying to identify who can move to who can be shifted to a primary healthcare center which is close by, and that would actually free up the ART centers, some of which are very overbooked and overclogged. at this point, and also allow for easier delivery of medicines to patients. One thing is, most of the people, a lot of provinces have now moved to multi-month dispensing, so 3 months instead of 1 month. I didn't realize Punjab still does 1 month dispensing. Is that true? Punjab maybe भी 1 महीने देते हैं दवाई, 3 महीने नहीं देते. 1 month. Yeah. So that's the other thing which will help retention is to just give more medicines so people don't have to come so frequently.
Yeah, exactly.
In Sindh, we have started integratory approach for communicable disease like TB, HIV, and hepatitis. So we are trying to give services for HIV at hepatitis sentinel sites as well, TB sites.
If you permit me, if I can share our experience in Malaysia, in the first decade and a half, ART was very much in the hands of infectious disease physicians like myself. And so the service was quite siloed, like it has been in many parts of the world. But in the last decade or so, we've really decentralized and for patients who are very stable. Initiation of treatment initially was also in the hands of ID specialists, but now I think many family medicine specialists are also initiating, and so it's very much integrated. And those who are coming to the tertiary centers are the ones with more complex issues. Yeah, so decentralization is definitely, I think, the way to go. And multi-month dispensing, which we were all forced to do during COVID, but it's now pretty shown evidence that it works. Any other lady in green, and then the person in brown and in black? Yeah.
My question is from Siddiq and Salman about the issues pertinent to gender specifically for women. When it comes to women, according to our experience, gender becomes the biggest problem for service provision. Dr. Humera, also for your consideration, we still do not have pregnancy kits as part of our package of services. We have to arrange that privately. And we are dealing with female sex workers, and even if we identify positive cases, we are not able to test them on any kit whether they are pregnant or not. So the program does not focus on identifying pregnant women. So how the service provider can deal with that? So please, if you could say some words about how challenging it is to get involved, the women, spouses of MSM and ID users.
Bushra, for us, I mean, the biggest challenge is to put PWID on the spouses. The influence of drug is the main factor that plays in between linking people. And luckily, most of the spouses, or all of the spouses, are not under the influence of drugs, and we have a support system to link them up, and we don't see that kind of attrition rate among the spouses of PWID. Though, I mean, gender barriers are there, and it's difficult for them to move out of homes and all, and that's why we strongly recommend different services for them also. Especially the ARV refills. I mean, that is something that is not should be conditioned with biometric verification and personal presence at the ART center. I mean, that's something is the biggest barrier. Otherwise, spouses, as far as spouses of PWID are concerned, we are much better as compared to people who inject drugs in terms of linking them up and maintaining them on ART.
When it comes to MSMs and their spouses, the society we are living in, a wife understanding that his man or his husband is homosexual, that is something which is very difficult to digest for a woman. So starting with that, a woman like she compromise on a certain way where there are kids, and then there is like this whole marriage concept. So yeah, there is it's not easy, like if we talk about the society we are living in, and like, and when the spouse, when they get to know about HIV and especially social media, unfortunately there is like so many wrong information is available and very less right information is. So with that, like when they started to understand what is HIV and how you get infected by HIV, and then this circus starts within the family and everything, and then this like whole kind of like defamation of the man and then everything that comes with it. So yes, it is difficult, but what I was like saying in the beginning, that we need, like in these situations you need professional help, couple counseling, a professional psychologist, a trained person who can deal this thing. So less and less chaos happen in this kind of situation. I think I've answered your question.
Yeah, that's good to hear, because, like I said, personally, it's one of the most difficult situations to be confronted with from a healthcare professional point of view. Because you mentioned consent, and there's always this balance between the confidentiality for the index patient versus your almost obligation to the partner to be tested. In the past, when there was an effective treatment, people could wait, but nowadays with effective treatment, you're really compelled to break the news. What do health professionals here do if the index patient refuses to give consent? Is there a law that?
Well, there is not a law, but if the client is not giving consent, there is no way we can reach to its family. Like, it's very simple. First, we have to like do counseling with the PLHIV and like letting him know, like not forcing him to bring his spouse, but like counseling and telling that if you want to like save your loved ones and if you want them to live and have a normal life, then like telling them why they have to bring their spouses for testing and letting know that what their status is about HIV, because they are the only, in most of the cases, the only reason they are on high risk is because they are partner of a PLHIV. So yes.
Yeah. We have a few. I think you were first. Yes.
अस्सलाम वालेकुम जी, सलमान साहब आप जरा ट्रांसलेशन कर देना। मेरा नाम है मोशी जान और ट्रांसकेयर ह्यूमन वेलफेयर फाउंडेशन मेरा नाम अदारे का है। सबसे पहले ये बात है कि जो HIV पॉजिटिव जिन बच्चों के ID कार्ड नहीं होते, चाहे वो FSW है, MSM है, एज वाइज बहुत छोटी होती हैं और वो पॉजिटिव होती है तो वो रजिस्टर्ड ही नहीं करती, इसलिए इतनी की प्रॉब्लम ग्रासरूट लेवल पर चल रही है, बड़े मसले चल रहे हैं इस पर। तो हम बार बार हर जगह पर भी कई भी मुशावरत भी की है कि इनको किस तरह हम इनको मेडिसिन दिलवाएंगे। तो इस पर थोड़ा सा गौर करना है कि मेडिसिन जो है ID कार्ड के बगैर भी मिलनी चाहिए और अगर वो पॉजिटिव है। दूसरे नंबर पे ये कि 1 मंथ से ज़्यादा अगर वो हमारे ट्रांसफर जैसा एक जगह से दूसरी जगह फंक्शन के लिए या इधर उधर जाते हैं तो वो बाज़ दफ़ा नहीं भी आ सकते, जो उनके पीछे फ्रेंड्स होते हैं तो वो जो है ना उनको मेडिसिन, जैसे हमें अदारे हैं हम उनको भी मेडिसिन, लेकिन वो बार बार यही कहते हैं कि 1 महीने की दवाई दे दी वो नेक्स्ट खुद आए। लेकिन कुछ इस तरह की पॉलिसी होनी चाहिए कि 3 महीने की कम से कम भी, अगर 1 साल या 2 साल वो मेडिसिन ले रहे हैं तो 3 महीने की मेडिसिन जो है ना वो काइंडली उनको देनी चाहिए। ट्रांसलेशन सलमान साहब कर दें।
I'm not very good at translation, but basically she's referring to the problem of children who are small and still don't have the CNIC or any registration number. with the family, so it's very difficult for them to get in, and that's something that I also mentioned in the presentation, that CNIC condition is quite harsh for putting people on it. And the other thing is that the multi-month dispensing should be there, so that if people travel for their work or for their own work, then they should be given at least multi-month dispensing for 3 months, so that they don't have to come back and again. And these are almost the problems that you have raised are quite similar to all PL-HIV, and that's the answer is differentiated services. कि लोगों को घरों पे दवाई मिल जाए या उनको करीब तरीन जगह में दवाई मिल जाए जो उनको कन्वीनियंट है, वही एक इसका जवाब हल है जो हम सब ने मिलकर करना है, किसी और ने नहीं करके देना हमें. So अगर हम नहीं करेंगे तो फिर ये नहीं होगा. जी जी. And that's something that she's referring to, that in Corona, and that's something that we also experienced as a very good experience, rather than being, I mean, most of the countries have faced problems during Corona times, but our attrition rate was very down in these times, because social mobilizers were able to get the medication because of Corona and were giving it at homes. So that was the time when most of the clients remained adherent, rather than, COVID making us difficult for us. When you have a mechanism and it's working, you can do much better job.
I would like to add something.
Yeah, Humaira, last words from you. I realize that there is a lot of interest in further discussion, but I've been reminded that the kitchen's going to take our food away if we don't wrap up soon. Dr. Humaira, last words from you.
Just a comment that I was in one of the meetings where this multi-month dispensing was discussed, and maybe Dr. can also put a light on it. But this is also one of the physicians' concern. It is a consented, agreed decision by physicians that the patient or person who is positive needs to come back to the center to get themselves checked. And there is a reason, obviously. They are suffering from chronic problem. They need to be checked. And also because they want to check that the person is taking the medicine. So there were some discussions around it, why 1 month and why not 3 months. So there is the physicians needs to agree as well that this is okay. So that I just wanted to...
Sure. Okay, what I would suggest is that you approach the speakers and the panelists at lunchtime or in subsequent sessions, because like I said, they're going to withdraw our food and we're all going to be very hungry. So thank you all for a really, really interesting session. It takes me back to the same issues that we face in Malaysia and still face in Malaysia. So I think there's a lot more to be discussed. Thank you very much, and we'll see you in the afternoon.